Hi, everyone, and welcome. My name is Abe Hittery. I'm part of UJA's Young Sephardic Division, which works to bring the amazing leadership, network, and resources of the UJA to our community. We are pleased to host this evening in collaboration with the Sephardic Community Center, SBH, and the SCA. It's been an extraordinarily difficult time for all of us. I want to extend my deepest condolences to the families and friends in our community who have lost loved ones, and wish refuah shelema to those still fighting the virus. Unfortunately, there are many misconceptions about COVID-19, and so tonight's program with leading physicians Dr. Salama and Dr. Stern will make us all better informed and safer. Before we begin, I want to take a moment and explain why UJA is so important to me and to us as a community. UJA's ability to respond in times of crisis is truly awe-inspiring. Their impact is felt not only in our own backyards, but nationwide. As the crisis first unfolded, UJA focused on addressing people's basic needs: food, employment, and essential health and human services. UJA then turned its focus to helping sustain Jewish community centers, assist low-income populations, and importantly, to ensure that no Jewish casualty of the virus be denied a dignified and proper Jewish burial. Just last week, UJA helped coordinate the repurposing of taletot from the SCA's summer minyan and deal to be used to meet the needs of the unfortunate recent surge in Jewish burials. The UJA is extending tuition scholarships for families in drastically reduced circumstances. Through our synagogues, UJA extended financial assistance to the newly vulnerable. The UJA provided direct emergency support to the Sephardic Community Center, in addition to a 7-figure interest-free loan. Beyond financial support, the UJA has provided technical and logistical support to many of our community yeshivot and synagogues, helping them navigate the complex application process of securing forgivable SBA loans. This guidance is delivering money that our institutions desperately need. The list goes on and on. UJA is always there for us and for our community, and we are truly grateful. Before we begin, one quick logistical note: please be sure to keep your line muted and to submit all your questions via the chat function at the bottom of the screen. We're going to do our best to answer as many questions as possible tonight. It is now my pleasure to introduce the moderator of tonight's discussion, someone I hold in such high regard that I married his daughter, longtime committee member and former president of SBH, Dr. Victor Grazi.
Thank you, Abe, and thanks to all the participants who've joined us this evening. In addition to thanking the UJA for coordinating and initiating this very, very important event, I think it's important that we also recognize the efforts of the SCC, who are providing so much daily provision of joy to our seniors, to our children through online programming. My friend Joey Tawil told me that each evening they have a dinner hour for our seniors who bring their meals to their table alone at home and can at least virtually have dinner with others and converse. Bikur Cholim, an organization close to my heart, has stepped up providing food and basic necessities for everybody. Our MedStar division is coordinating hospital needs of inpatients, referring people for proper testing. And of course, the SCA put together our doctors group, which started on a Saturday or Sunday night, I remember about 6 weeks ago, with 2 or 3 members. We're now up to over 150 community members, physicians, nurses, EMTs. And we not only exchange information, but we help one another to help families in the hospital. So if someone knows of a family member at Methodist or at Mount Sinai or at New York Hospital, other doctors on the chat can reach out and check as to their status. For those of you who don't know me, I've been practicing obstetrics and gynecology in the community for over 3 decades, and I am not an infectious disease specialist. As such, I'm extraordinarily grateful to be joined tonight by 2 experts in the field. Dr. Carlos Salama is an infectious disease specialist and an associate professor of medicine at the Mount Sinai School of Medicine. He practices at Elmhurst Hospital, which, as you know, has been identified on the national news as the epicenter of the outbreak here in New York City. We're also very grateful to be joined by Dr. Aaron Stern, who is an assistant professor of medicine at Mount Sinai School of Medicine, a nephrologist by training, and has been called up to work in the intensive care units at Elmhurst. So I'd like to begin the program officially by asking both Dr. Salama and Dr. Stern to share with us how they arrived at their present positions treating COVID patients, what they were doing previously, and how it has evolved. And then we'll get into a more robust question and answer period. So please share with us your thoughts and your experiences.
So I'll begin. I want to, first of all, thank all the hosting organizations for having us, and Dr. Grazi for moderating, but also especially UJA Federation for all the work that you're doing in the community in New York and in Israel, and all the help that they're providing. It's really been invaluable. I would have to say 6 weeks ago, I was just a sort of a regular kidney doctor, doing hospital medicine, seeing kidney patients, doing clinics, and probably within about 72 hours of the outbreak, the hospital was pretty much converted to an almost complete COVID hospital where every patient who was coming in had this virus. And it really pretty much changed the face of the hospital so that we quickly discharged people who were not infected. And for the last 6 weeks, we've been pretty much treating almost 100% patients with the virus. And the last week or so, it's actually gotten somewhat better. So there really has been some improvement. But it's been all hands on deck, 24 hours a day at this point, or up to this point.
Thank you.
Yeah,
Dr. Salama, can you give an introduction, please?
Yeah, I'm an infectious disease doctor, as was mentioned, and my main role has been as an HIV provider for a lot of HIV patients in the community. And then I do a lot of infectious disease consults in the hospital. So I do a lot of inpatient hospital work. And as Dr. Stern mentioned, the last 6 weeks has turned us completely upside down. I've become a full-time COVID doctor and researcher now, trying to get a whole bunch of medicines studied and looking for data on all types of treatments for this disease to try to be a support for the hospital's doctors. And it's been a very difficult, stressful time. What I'd like to get out from the get-go is that this is not the flu. A lot of people talked a lot about this is just a bad flu. We have never seen the flu do anything remotely to what is happening right now in our hospital, where we at our height had 160 patients on ventilators, and so many people in New York City were dying. And this is after a shutdown of the entire city. The flu is extremely mild compared to this, and this has been really a catastrophic event for the city of New York and the United States. I think we need to take this disease, continue to take this disease pretty seriously, and I hope that's what we continue to do.
Thank you. The reason I asked each of you to give that introductory remarks about what you've been doing is because, understandably, this is a rapidly evolving situation, and particularly in a case where lay people and physicians alike are under stress, and we're frightened, and we're fearful for ourselves and for our family. There's a lot of misinformation, and there's a lot of misinterpreted information that's available, particularly through social media. Some of it politicized, some of it it's evolving and it's changing. So I think it's critical that we have you here tonight to answer some fundamental questions, and I'd like to begin to dive right into that, because that's truly what our audience is here to appreciate. So the first thing is, if you could share with us the population most greatly at risk, and also what symptoms should somebody be alert to that will require them to seek care in an emergency room in a hospital setting rather than stay at home, particularly since a lot of conventional medical offices have not been accessible. Either of our panelists.
Right. So I'll tackle that. Sort of from a kind of a sort of a community lens, it's very clear that nursing home patients, as we know, are uniquely vulnerable. And that has to do with sort of close quarters, as well as their age and their comorbidities. And living in those close quarters is very easy for a virus to be able to be transmitted among members of a nursing home. In terms of hospitalizations, it's very clear what we're seeing is that age really is not a limiting factor in this disease. Certainly, people under 18, probably with one hand, you can count how many patients we've had, and it's quite rare in children, or almost non-existent. But as you hit age 20 and above, the numbers begin to increase, and probably over age 60 is where the numbers really significantly increase. So it's age is a factor, as well as comorbidities, and specifically blood pressure, high blood pressure, diabetes, heart disease, and obesity are probably the 4 biggest factors, with high blood pressure seeming to be the one that is the most impactful.
So if someone believes they may have the virus, what recommendations can you provide regarding whether to stay at home or seek medical care?
Well, if someone believes that they're sick and has a virus, then they should seek some form of medical attention. So calling their physician or trying to get some information about what they have, because not everybody has the virus, although quite frankly, right now, most people who are sick do. So the common symptoms would be fever, body aches, diarrhea, cough early on. And then as the disease progresses, people start to feel short of breath. And of course, most people do not get to the stage of shortness of breath. A lot of people just get a flu-like illness that I just described without the shortness of breath. And many people don't have any symptoms at all. So the question then becomes, well, when do you go to the hospital? When do you seek medical attention? Generally speaking, when my patients call me and they tell me I am sick, I have to assess, well, what kind of a patient are they? What kind of medical problems do they have? Are they immunocompromised? Are they over a certain age? Do they have comorbidities? And then we'll decide together about what the right course of action is. The best thing to do would be to test a large swath of the population, everyone who's symptomatic, and then all their contacts. But that has not been available so far due to the limits on testing that we have had as a society. And so, what I would suggest to people is if you feel sick, call your doctor, get advice from your doctor about what the next step should be. And certainly if anybody feels short of breath, that they should go to the emergency room. Now, very interesting thing about this disease is that many people have breathing problems, but they don't feel it. So they don't feel short of breath, but when they get to the emergency room, their oxygen needs are required. So one thing people can do is, and this is a fairly cheap thing, is purchase a pulse oximeter and have it at home. And if they get sick, put that pulse oximeter on their finger and follow it. Most people should have a pulse oximeter of 97 and higher. And if you're 94 or lower, then you should be concerned, unless that's your baseline, right? If someone has, let's say, underlying lung disease. But most people, 94 or lower is going to be problematic. And so that's a quick test that people can do and follow. Now, just keep in mind that some pulse ox give erroneous results, but for the most part, a low result on that would be concerning and would lead someone to go to the emergency room in addition to someone who's short of breath.
I think it's important that we point out when we talk about hospitalizations, across the board, all the hospitals in the region have seen a markedly decreased number of people presenting with illnesses unrelated to COVID. There's at least a 50% reduction that I've read in people presenting with otherwise very critical illnesses such as heart attacks and strokes. Obviously, COVID is not protecting against that. It's all the result of people being fearful. And I think once this pandemic, please God, comes to an end, we're going to see that there's been a lot more damage to society and probably a higher mortality rate for people who are fearful of seeking out care. So I think it's important that we share with our audience that even with non-COVID situations, if you believe you have a serious, urgent medical problem, that you seek care. Please don't be fearful about presenting to the hospital if you have symptoms suggestive of any significant illness, totally independent of the COVID pandemic. Let's move on, please, if we could, to testing, because that's really what everybody seems to be worked up about and where there's a lot of recent developments. So can you please explain to the audience the difference between the nasal swab testing and the subsequent development that's getting most of the recent publicity about the antibody testing?
There are two types of tests. One of them is what we call an antigen test, which is looking for the actual virus. And the other one would be an antibody test, which is looking for our immune response to that virus. So when we go and get a swab in our nose or in our throat, what we're looking for is the actual antigen or the virus itself. And we do this with an RT-PCR test. And that test has about a 70% sensitivity, which means that up to 30% of people who get that test might test false negative. So getting a negative test does not rule out the possibility that one is infected with the virus. That becomes more of an issue in patients who are without symptoms, because patients who are symptomatic and present to a hospital and have a flu-like illness during the period of the pandemic like this, we can basically assume that they have this virus where they test negative. And especially when they have pulmonary infiltrates, when their chest x-ray has infiltrates in it, they're very typical of this disease, and we can tell when patients have this disease. So the bigger problem of the swab being a false negative is in people who are asymptomatic, and we're trying to do contact tracing and stop the spread of the disease. The serology test, or the antibody test, is a blood test. And that is when you take the blood and you look for immunoglobulins to the virus. And so that's important in trying to figure out who's been already exposed and who potentially may have immunity. And there are many questions about this right now, because we are not 100% sure that everybody who has positive serologic tests is immune to the disease and will prevent them from getting infected again. Most authorities believe that immunity will occur with this virus after one gets over it. And in fact, if you look at the SARS-1 epidemic, which was a much smaller epidemic with a much less contagious virus, but was more severe in that it killed more people that it infected, that viral infection, the people got over that, had immunity to the virus for several years. And so there are a lot of unanswered questions about the immune test. And also there's been so many companies that have come out with a test, and not all of them are validated. And so we're not 100% sure that they're all very accurate. And there's a lot of studies going on right now to determine which tests are most accurate and which are not the most accurate. And if you really want to get tests, sorry.
It's also important to point out that a lot of people out in the community, different communities, are offering the tests for a lot of money. And it's very clear these are not well-validated tests. So there's a lot of, you really should be going to like either a doctor's office or a large hospital to really get a more valid test. And the test will be refined in the next few months. It will be better and better. But at this point, I would sort of avoid, seeing an ad in the on a handbill saying, come get the test and, get it done, and be reassured in any way.
So the question that everybody's asking is, I tested my antibodies, they're positive, I can go out and re-engage and visit grandma. I need you to respond as accurately, truthfully, and I dare say as forcefully as you're comfortable doing so, please.
Well, if someone has a positive antibody, that means that they did get over an illness, and that's great for them. We're not 100% sure that all those people's nasal swabs are negative, and we don't know that they can't be infected again. And since grandma is the highest risk person that I would avoid grandma until we have a lot more scientific information about infectivity in those people.
And you alluded to the lack of validity of some of the tests. Would you suggest that people restrict their use of the tests to the major laboratory carriers? Are those more likely to be accurate and verifiable? The Quest Labs, they came out with an announcement today of being able to be tested actually without the direction from your physician. So are those major national labs likely to be more accurate?
Those I would say would be more accurate, but also if you go to a hospital where they are offering the test, I think it would be more reassuring than going to someone who, in their garage is saying, I'm giving the test. I got a bunch of batches of, the antibody assay from China. And that to me is just, would not be as reliable.
I sort of frankly don't see much utility at this point in the screening other than two very specific situations. One would be if you're considering plasma donation, which we'll talk about in a moment when we get to treatments. And I know there have been some drives here in our community through Hatzalah. Thank you very much to a wonderful organization for spearheading that, through the Mayo Clinic. I know Mount Sinai, where all of us are on faculty, are running a similar program. So if one believes they recovered from COVID and interested in potentially donating their plasma for treatment, there's value to the testing. The other would be on an epidemiological or a public health level, where the government and our public health officials are trying to gauge a sense for what's actually going out in the population. I don't really see, other than those two situations, as of today, I personally don't really see much of a validity or a utility, a real reason for an individual to be tested. Would you agree with that comment, and would you like to modify that in any way?
I would just modify that. The other reason would be to try to figure out what the likelihood of reinfection is in people who have been infected and test positive for the antibody. We are hopeful, and I think it's going to be likely that most people who get infected and develop immunity are likely to be immune to getting reinfection, and that would be very important to find out with these tests.
I'd like to move on, if we can, to treatment. And I touched briefly upon one of them, the antibody to plasma program. Can you speak to that, as well as to the announcement today of some preliminary findings that were hopeful regarding the remdesivir and any other treatments that you're aware of that are in studies and that we perhaps can be looking forward to prior to the development and wide distribution of the vaccine?
Right. Well, I'm going to let Dr. Salama speak about the specific treatments. I do have to say that there's not a magic bullet right now. There's a lot of data coming out and will be coming out in the next few months, and I think we'll have a clearer idea. But at this point, we almost really have what we call supportive management. We do find that very ill patients, if we turn them on their sides or on their stomach, it increases their oxygen levels dramatically. And we're also believe that using blood thinners seems to impact some of the manifestations of this disease, which is very aggressive clotting throughout the body. We don't have evidence absolutely that is completely effective, but our sense is it does seem to be having a bit of an impact, and we'll know more in the future. The next several months, I think we're going to be much better at identifying medications and treatments that are effective. But right now, we're still in those woods where we just don't see clear patterns.
Yeah, I agree with Dr. Stern that right now the best treatments that we know are helpful are going to be turning patients on their stomachs mainly, and probably anticoagulation. Now, there are two types of direct treatments. One is going to be antiviral treatments that actually go after the virus themselves, and the other are going to be immunologic treatments or immune modulating treatments. So the antiviral treatments that we've heard a lot about have been the chloroquine drugs, azithromycin, the two antibiotics. And up until now, there hasn't been any large prospective studies to come out and either support or refute their ability to treat. We have not seen dramatic improvements in patients treated with these drugs. So, it's possible that they have some effect, because I think we're going to need a multi-treatment regimen to treat this virus. So it's possible that one or two of those drugs may have some effect. Another drug that it was in the news today would be remdesivir. And remdesivir is an antiviral drug that was initially developed to treat Ebola virus in Africa. And it seems to have some activity. The data today showed that although there was no mortality benefit by use of the drug, people got over it quicker. So there was a shorter course in the hospital in patients treated with remdesivir. And that's very hopeful. And so, the other drugs that were looked at earlier as antiviral drugs really haven't panned out that much. And so now we're left with these immunologic therapies. So there's a lot of monoclonal antibodies, interleukin inhibitors, all these immune modulators that try to prevent that cytokine storm. So what does that mean? Well, it turns out that around a week into your symptoms, patients develop what we call a cytokine storm. That means that their immune system basically attacks them and causes them to get all this multi-organ failure. And part of that attack damages the endovasculature, which is the inside of the vessels, and causes a lot of lung disease and kidney disease and heart disease and all kinds of problems. And so what we're trying to do by giving these medications like interleukin-6 antagonists, for example, is to try to stop that immune-mediated phenomenon that we're having occur in ourselves. And interleukin-6 has been one element of our immune system that seems to have a large role in this disease. Up until now, those drugs have also, they have shown some partial effect in some studies. They haven't shown like a dramatic effect yet, but more are being studied. There are many different types of these drugs, and more are being studied. So we're all very hopeful that these drugs are going to be effective. And then there's the plasma treatment, which is something that has been used for probably a century now, where you take the plasma of a person who's gone over the illness and you put it into a person who's sick with it. And the idea is that if there's a lot of what we call neutralizing antibodies, meaning immune cells that are already prepared to attack the virus, and you put them into someone who needs them, that those will neutralize the virus and help them get better. And there's really two ideas behind plasma working. One is the fact that there are these antibodies that can attack, but the other thing is that plasma itself has a very good effect on people with endovascular injury. So it is an endovascular stabilizing agent, which means that whatever injury is happening inside our vessels can be helped by regular plasma. And so there may be a dual effect of convalescent plasma, not just from the antibodies, but also with the regular factors that are in plasma itself. And so that's also very, very hopeful. And so now there's just, we just have to be patient. And the important thing here is that we need to do studies. Steroids is the other thing that we haven't brought up. That's kind of like more of a general immune anti-inflammation agent. So we have no data on steroids, and steroids have been felt to be ineffective for other viral illnesses that cause this type of damage, but in this disease may be effective. So what I would say is right now, we need to do studies. We need to figure out how to treat this, because as this wave goes away, if God forbid another wave comes back, we need to be better prepared than we were this time to treat this illness.
One study that they're actually doing at a couple places in the United States, you had asked me earlier about which patients are vulnerable or at risk. In terms of statistically, men seem to be getting sick at a ratio of about 55-45 men to women. But when you look at people who are critically ill, intubated in ICUs, it really rises to about 80-20. And they're actually doing experiments giving men progesterone and estrogen, trying to figure out why women seem to be somewhat more protected, especially at younger ages. And so that's sort of something, but it's many different medications and drugs are being tried right now.
I'd like to, in the few minutes remaining that we have, open up to a few questions. As the weather's getting warmer and as we've been under lockdown, quarantine, or whatever euphemism you choose to employ for 6 or 7 weeks now, and the clannishness of our community begins to rise to the fore, where everybody wants to move into their parents' house and deal with their 4 siblings and 26 nieces and nephews. A lot of the questions that are coming through on my phone are regarding the question of what can we do in terms of families reintegrating for the summer? Can we combine family households? Some of the questions are just generic in terms of that, and others have to do with, I know that both myself, my husband, and my parents have all had COVID. As such, if we all believe we've had COVID or we're tested as being positive and have recovered, can we get together? This is going to be, I think, the next big challenge for our particular community in the next several weeks. So if you could, Dr. Stern, if you could address that, please.
I mean, I think to me, it comes down to how much risk one wants to tolerate and accept. I mean, if one has an elderly grandparent and you feel like you had the virus, but you weren't really tested, you're taking a risk. And so it would be wiser to try to sort of at least keep the very vulnerable population still, not necessarily locked down, but away from children who might be carrying it, who aren't getting sick, or people who've had it and may still be shedding virus. We just don't really know yet. And, we'd like to think warm weather, the virus stops, but so far it's not totally clear that that is happening, especially in other parts of the world.
Thank you. I think it's important as we begin to wrap up that we continue to give honest facts to our audience, but I'd like to end with each of you giving us perhaps a summary statement or a reason that we can be hopeful. I believe we've made a lot of progress in the last 7 or 8 weeks. I think the medical knowledge today compared to early March, mid-March, has been exponential. We're not yet near where we need to be. I think we need to encourage everybody to continue to practice the social distancing that has flattened the curve. I watch the governor's press conferences daily, and you see the numbers. He reports the numbers. Again, as he calls it, statistics and facts, not opinion. They're coming down. This is not a time to be complacent. I think we should emphasize that. But I would very much appreciate if, again, based on your own personal experiences, working on the front lines, as well as the scientific data that's come out, please leave us on a reason that we can be hopeful and end the meeting in a way where we can look forward to the future.
Well, I would say it would be fair to say that we're at an inflection point of American history. And the last 6 weeks have really been pretty awful for both, hospitals in the United States. And we are emerging through this, and we've learned a lot. And I believe the next few months to the next few years, I think we're going to have a better grasp with all sorts of treatments, and it will be more manageable. And I think we'll be better prepared. The government at both the city, state, and federal level will be better able to mobilize in the next wave. And the next wave will be happening, will likely not be as big, but we certainly can understand that we've not conquered this virus yet. So I think reasons to be hopeful is we've learned a lot, and I think we're going to be better able to manage things. And vaccines that Dr. Salama may want to talk about are sort of, I think, the next thing that may be quite helpful.
Dr. Salama, please.
Yeah, so, one silver lining of the HIV epidemic of the last 40 years is that our knowledge of virology has grown tremendously. We would not know what we know today about viruses, about vaccine development, and about immunology if we didn't go through this, terrible 40 years of trouble with this virus. But on the bright side, there is so much hope right now that the science community is going to figure out how to vaccinate this virus quickly and how to treat this virus quickly. So I'm very hopeful that some good treatment will come on the horizon. And, there was data just released from Oxford University where they have a vaccine already that's being tried on I think it was macaques, where those macaques who were getting infected with the virus and getting sick from it, once they gave them vaccines, they were no longer getting infected. So it's a proof of concept in very close animals to humans. And so I'm very hopeful there's going to be a vaccine within a year and a half. But we're going to have to be careful. As Dr. Stern said before, we may get a resurgence of this sometime in the fall, for example. The pandemic flu of 1918 had 3 big peaks. And so this may happen, this may not happen, but I'm very hopeful that the medical knowledge nowadays is really going to make a difference. And I just want to say one more thing, and that is that the nurses, the doctors, the residents in these hospitals that you see, it's just been absolutely tremendous. The work that a lot of our young house staff have done, and nurses, it's been prideful to watch these people at work. And I think with these kinds of people working in hospitals, we'll do well.
Thank you very much. We're about running out of time. Unfortunately, we've not been able to get to a number of the questions that have come through. If my expert panelists are willing, perhaps we can reconvene at another time and field questions specifically without the preliminary discussions that we had. So I'd like to thank both of you very much.
Thank you.
I know you both must be exhausted physically and emotionally, and for you to take the time to serve the community is deeply appreciated. And thank you again, UGA.
It's an honor.
And all the partner organizations. Thank you, everybody. Please stay safe and have a good night.
Thank you.
Thank you.
Good evening. I'm Joey Tawil, CEO of the Center. Thank you all for joining us this evening. Thank you, doctors, for your expertise and insights. We are truly grateful for your time. Thank you, Dr. Grazi, for moderating the conversation. It's important that we continue to listen to the experts and stay abreast of the information in order to remain healthy and strong for our families, our community, and our future. To stay up to date on the community's resources, please visit the SBH website, the Center's website, the SCA's Instagram page for upcoming classes, and UJA's COVID Response Relief. Please visit their website. The Center would like to thank the SBH and the SCA for helping to promote this evening's call, and UJA for all that you do to help support our community and for organizing this evening's program. Have a good evening, and please stay safe and please stay inside. Thank you.